Welcome to a new deep dive. Today we're tackling a really important and frankly complex subject straight from your sources. Chapter 89 on gynecologic malignancies.
hmm
This chapter lays out the landscape of cancers affecting the female reproductive system, and our mission today is to go incredibly deep. We want to pull out all the vital info, the surprising facts, so you can really master this.
That's the plan. We've got a lot of ground to cover here. Everything from the more common cancers like ovarian and uterine, right through to the less frequent ones like gestational trophoblastic tumors.
And we'll be digging into origins, symptoms, diagnosis, treatments, all based strictly on the material provided in this chapter, right?
Exactly. No outside info, just what's here. It's a dense chapter, but we'll help connect the dots and make sense of it all.
Think of this as your shortcut to getting an expert-level handle on this material. We're just diving deep into these pages. So let's jump in. Where should we start? Maybe with one of the most challenging ones, ovarian cancer.
Sounds good. Okay, ovarian cancer. Let's unpack its impact first. According to the chapter, it's still a leading cause of cancer deaths for American women.
Yeah, I saw that. Behind lung, breast, colon, pancreatic, still very high up the list.
It really is.
No.
Significant concern.
And the ovary itself, it's not just one thing, is it? It's complex. How does that play into the kinds of cancers we see?
That's a great point. The ovary is incredibly complex biologically. Think about its functions during reproductive life. Menarche around 11-13, menopause around 45-55, hormones, eggs, ovulation.
Right, lots going on.
Exactly, and that involves different cell types. You've got the stromal cells, the germ cells where eggs come from, and then the epithelial cells covering the outside. And here's the crucial part. Cancers can start in any of these groups.
And they behave differently depending on where they start.
Totally different. The source really emphasizes this. Epithelial tumors are the most common overall when you find an adnexal mass, near the ovary.
Nexal mass.
Right. So of those epithelial ones, maybe half are benign. About a third are malignant cancers. And then around 16% are this borderline category, low malignant potential.
Interesting. Does age matter there?
It does. The chapter points out that tumors in younger women are more likely to be benign. Makes sense.
Okay, so for the ones that are malignant epithelial cancers, which types are most common?
Serous tumors are the big one. The source says maybe 60 to 70%.
Oh yeah, the majority.
Yeah. Then you have mucinous, endometrioid, and clear cell types, each making up roughly 10 to 15%. And the chapter notes these proportions can actually vary a bit geographically.
What about the less common ones, stromal and germ cell?
Right. Stromal tumors come from those supportive hormone-producing cells. Usually they don't make hormones, but sometimes they do, leading to some specific symptoms.
Huh.
And germ cell tumors. Fascinating. They're basically the ovarian version of testicular tumors. They come from those very basic cells that can become anything. Their behavior is different, and their location in the abdomen affects how they spread compared to testicular cancer.
Right.
And one other really important point the source makes, sometimes cancer found in the ovary actually started somewhere else.
Metastases.
Exactly. Breast, colon, stomach, pancreas. It happens. They even mentioned Krukenberg tumors. Those are specific metastases from GI cancers. It just highlights why you often need a wide search when diagnosing.
That's a great overview of the types. Let's circle back to the most common epithelial ovarian cancer. What's the lifetime risk for an American woman?
The source puts it at about 1 in 72, so around 1.6% lifetime risk. And yeah, most of those will be epithelial. The 2021 estimate was roughly 21,500 cases and over 14,000 deaths in the U.S. Pretty sobering numbers.
Is it mainly a disease of older age?
Peaks in women in their 50s and 60s, the sporadic kind.
Yes.
But, and the chapter makes this clear, the age range is really wide. You can see it from the third decade right up into the 80s or 90s.
What drives that risk? Is it just genetics or are other factors involved, like lifestyle?
It seems to be a mix. The source calls it an interactive mixture. Epidemiology, environment, genetics. Factors linked to higher risk include nulliparity.
Nulliparity, meaning never having given birth.
Correct. Also obesity, certain dietary factors, some infertility treatments, and possibly hormone replacement therapy, though the source flags that one as a maybe.
Interesting. So things women experience. What about things that seem protective?
Yeah, there are protective factors listed too. Using oral contraceptives, having multiple births, multiparity, tubal ligation.
Having your tubes tied.
Yes. Also aspirin use and breastfeeding. The chapter does mention that perineal talc use is still controversial.
Do we know why those things are protective, the mechanisms?
The chapter says it's largely unknown, but the theories revolve around maybe suppressing ovulation, changing hormone levels, or reducing inflammation. and the constant repair the ovary goes through after ovulation. Anything that gives the ovary a bit of a break, potentially.
Okay, that makes sense. Which brings us to the why, the genetics, and how these cancers actually start. The source talks about type 1 and type 2. What's the main difference?
Yeah, this is a key distinction. Type 1 cancers are generally low grade, meaning they look less aggressive under the microscope and they tend to be indolent, slow growing. Type 2 are the more aggressive, high grade ones.
And presumably different genetics underlie that.
Yes, definitely. Type 1 cancers often have specific mutations, things like KRAS, BRAF, PTN, PIK3CA mutations. Type 2 genetics are different.
Now, this is where the chapter presents something that feels, well, surprising. It suggests that type 2 cancers, the common, aggressive, high-grade, serious ones, might not even start in the ovary.
That's right. It's a major shift in understanding that the source material highlights. And yeah, it is surprising. Studies cited suggest many, maybe most of these, actually originate in the lining, the epithelium of the fallopian tube.
The fallopian tube, not the ovary.
Correct. It seems the initial genetic changes often happen there. Things linked to early losses of the TP53 gene, problems with DNA repair, especially involving BRCA1 and BRCA2.
So the idea is cancer starts in the tube, cells break off, and then they land on the ovary and spread from there.
Precisely. These transformed tubal cells pick up more mutations, they shed, they travel. The source even mentions they seem drawn to cells expressing something called mesothelin, which helps them stick to the ovaries and spread in the peritoneal cavity.
Wow. Okay, beyond that tubal origin and the early gene hits, what's a bigger genetic picture for type 2 serous cancer?
The Cancer Genome Atlas work, described in the chapter, found these cancers are often genetically chaotic. Lots of large-scale changes, chunks of DNA amplified or deleted, rather than just single-point mutations.
Like genomic instability.
Exactly. A defining feature is loss of TP53 function that's seen in over 95% of cases. And damage to those homologous DNA repair genes, especially BRCA1 and BRCA2, is also really common. Less frequently, you see mutations in NF1, RB1, CDK12.
Which brings us neatly to the inherited risk. BRCA1 and BRCA2 mutations. How big a factor is inheriting one of those?
It's the most common heritable factor. A germline mutation one you're born with in BRCA1 or BRCA2 significantly bumps up the lifetime risk for both breast and ovarian cancer.
And the numbers are pretty stark, aren't they?
They are. For BRCA1, the lifetime ovarian cancer risk is quoted as 39.63%. For BRCA2, it's 16.527%. Compare that to the 1.6% general population risk.
Yeah.
And breast cancer risk is even higher for carriers.
So a strong family history, multiple cases, early onset, that's a major warning sign.
Often, yes. And the chapter notes BRCA2 mutations also raise risk for male breast cancer, pancreatic, and prostate cancer. For women with BRCA1, the ovarian cancer risk is particularly high, often hitting in their 40s or 50s. BRCA2 is a bit lower risk for ovarian, and onset tends to be later, 50s or 60s.
Are there other inherited risk genes mentioned?
Yes, though they're less common. The source mentions mutations in other DNA repair genes, like PALB2, can play a role, but the risk isn't as well defined. And importantly, it links ovarian cancer to Lynch syndrome. That's the HNPCC type 2 we usually associate with colon cancer.
Lynch syndrome, too.
Yes, caused by mutations in mismatch repair genes like MSH2, MLH1, etc. Women with Lynch syndrome can get ovarian cancer relatively young, often before 50.
Okay, let's shift to how women actually experience this, the clinical presentation. What are the typical symptoms?
Well, this is the crux of the problem, as the chapter really emphasizes. Early ovarian cancer tends to be silent, painless, unless the ovary twists on itself torsion.
So no obvious early warning signs?
Often not. The early symptoms are usually really vague, non-specific things. Bloating, feeling full quickly after eating just a little, maybe some general GI upset.
Things that could be anything, really.
Exactly. And the source says they're often dismissed, both by the woman herself and sometimes by her healthcare team, until the cancer is much more advanced.
So persistent bloating or feeling full? Those could be red flags if they don't go away.
They potentially could be, yes, especially if they're new, persistent, or getting worse.
Mm-hmm.
The chapter also mentions things like pelvic discomfort or maybe urinary changes, but because they're so non-specific, they often fly under the radar early on.
What about when it is advanced? What are the signs then?
The most common way advanced disease presents is after a period of these vague symptoms getting progressively worse: nausea, ongoing bloating, indigestion, constipation, abdominal pain. But the sign that often really triggers alarm bells for both patient and doctor is a rapid increase in abdominal size.
From fluid buildup.
Exactly, ascites. That buildup of fluid in the abdomen is a key sign. It suggests the malignancy is causing pressure or has spread widely. The chapter does note, though, that the exact how and when it spreads beyond the ovary, well, it's still not perfectly understood.
So given it's often caught late, how is it actually diagnosed when these signs appear?
Imaging is key. Radiologic evaluation, usually CT scans, these often show a complex mass near the ovary. The ascites fluid, signs of spread on the lining of the abdomen, that's carcinomatosis, and maybe enlarged lymph nodes. The source specifically says PT scans usually aren't needed initially.
What about blood tests? I know CA-125 is often mentioned.
Yes, lab tests frequently show a high CA-125 level. That's a protein shed by the cancer cells. But the chapter makes a really critical clarification here. CA-125 is associated with ovarian cancer, but it's not specific to it.
Meaning other things can raise it.
Exactly. Benign conditions, other cancers. So it's not a perfect diagnostic test on its own, more of a clue.
How is the extent, the severity measured? Is there staging?
Yes, there's a standard staging system, I through 4, which is detailed in Table 89-1 in the source. Stage I means it's confined to the ovary or ovaries. Stage 2, it's spread within the pelvis. Stage 3 means it's spread within the abdominal cavity or to retroperitoneal lymph nodes. And stage 4 means it's spread outside the abdomen, like to the liver parenchyma or fluid around the lungs.
And survival rates vary dramatically by stage.
Hugely. Stage 1 has excellent survival, like 88-95% at 5 years. Stage 2 is still pretty good, 70-80%, but stage 3 drops significantly, maybe 20-40%, and stage 4 is very low, around 17%. The chapter points out that stages 1 and 3 are further subdivided. And here's a key statistic. The most common stage at diagnosis, for about 70% of women, is stage I.
Stage I start, meaning bulky disease in the abdomen or positive nodes.
Correct. So most women are already diagnosed at an advanced stage. The other 30% are spread roughly evenly across the other stages. That survival difference is just, yeah, it's stark.
It really underscores the need for early detection. So is there effective screening for ovarian cancer?
That's the million-dollar question, isn't it? Given how treatable it is early versus late. But the source is very clear on this. Currently, screening for ovarian cancer is not recommended for the general population outside of a clinical trial setting.
Really? Even with markers like CA-125 and ultrasound? Why not?
It comes down to the low incidence in the average population. Remember that 1 in 72 lifetime risk. At any given time, the number of women with an undetected early cancer is very low. The chapter estimates maybe 1 in 2,000 women aged 50-60.
Okay.
So for a screening test to work, it needs to be incredibly good at picking up the few actual cases, high sensitivity, and incredibly good at not giving false alarms, high specificity.
And our current tools just aren't specific enough. Lots of false positives.
Exactly. The source states that even panels of markers haven't done better than CA-125 alone. Strategies using algorithms with serial CA-125 checks haven't panned out either. No other strategy has proven successful yet. You'd end up doing a lot of unnecessary, potentially risky follow-up tests and surgeries on healthy women.
And those follow-up procedures could actually cause harm.
That's the concern. The text mentions some large studies even suggested screening might worsen mortality, likely due to complications from investigating those false positives.
Wow. Okay, what about for the high-risk women, those with BRCA mutations? Surely screening is better for them.
You'd think so, but the source addresses this head-on. It says, and I'm quoting the essence here, screening studies, even in BRCA families, suggest that available techniques like serial CA-125 and transvaginal ultrasound are still insufficient to reliably detect early-stage ovarian cancer in prospective testing.
That's quite definitive and disappointing. So screening isn't the answer currently, even for high-risk groups, unless it's part of research.
Precisely the takeaway from the chapter. What is recommended, though, is testing women diagnosed with ovarian cancer for germline BRCA mutations.
Why test them after diagnosis?
2 main reasons. 1, it identifies patients who might benefit from specific treatments like PRP inhibitors. 2, it helps find at-risk relatives who can then access genetic counseling and preventive options.
And what are those preventive options for high-risk women?
The main recommendation is risk-reducing surgery, removing the fallopian tubes and ovaries, called a prophylactic salpingo-oophorectomy, ideally after finishing childbearing and often recommended before age 40.
And does that work? Does it significantly lower the risk?
Yes. The chapter calls it highly protective against ovarian cancer. And it adds an interesting bonus. It also seems to cut the risk of later breast cancer by about 50%.
That's significant. What about just removing the tubes, since they seem to be the starting point often?
Prophylactic salpingectomy, just removing the tubes, is definitely considered a key part of prevention now. The benefits of just removing the ovaries alone, isolated oophorectomy, on cancer risk aren't as clearly defined, according to the text.
Okay, let's move to treatment once a diagnosis is made. The source talks about different disease states guiding the approach. What's the first step usually?
Surgery, performed by a gynecologic oncologist who specializes in these cancers. That's the preferred initial therapy.
Mm.
And how much cancer is left after surgery is a huge predictor of outcome.
How does that initial surgery work if there's just a suspicious mass?
Right. If a woman presents with a localized mass, the first goal of surgery is to figure out, is it benign or malignant? And if it's malignant, where did it start, ovary or somewhere else? The source explicitly warns against needle biopsies before surgery because of the risk of spilling cancer cells.
Okay, no needle biopsies. So what happens in the OR?
Typically, it starts with a look using a scope laparoscopy and removing the affected tube and ovary for a quick pathological diagnosis. If that confirms primary ovarian cancer, or if they already see spread during laparoscopy, the operation gets much bigger.
Bigger how?
It extends to what's called staging and debulking surgery. That means removing the uterus, the other tube and ovary, the omentum.
The omentum again, that fatty apron.
Yes. Plus sampling lymph nodes in the pelvis and along the aorta, and taking biopsies from the lining of the abdomen and the diaphragm surfaces.
That sounds incredibly extensive. Why is such a major operation necessary?
The chapter explains it's because even when the cancer looks confined to the ovary, microscopic spread has already happened in about 30% of cases to the abdominal lining or lymph nodes. So this big surgery aims to remove all visible disease, or at least as much as possible. That's the debulking or cytoreduction part.
You mentioned lymph node sampling. Is removing all the nodes better?
The source suggests node sampling is mostly for staging, finding out if cancer has spread there, similar to axillary nodes in breast cancer. But doing a full lymphadenectomy, removing all nodes, doesn't seem to add significant therapeutic benefit based on the text.
What's the ultimate goal of that debulking surgery?
The ideal goal is an R0 resection. That means no visible residual cancer left behind. The chapter also mentions optimal resection, meaning no spot of cancer left that's bigger than 1 centimeter. Achieving R0 or optimal resection leads to a much, much better prognosis than leaving larger amounts of disease behind, which is termed suboptimally debulked.
What if the surgeon realizes during the operation they likely can't get down to that optimal level?
In that situation, the recommendation is actually to stop the big surgery, close up, and give the patient chemotherapy first.
Chemo first, before removing the tumor.
Yes, that's called neoadjuvant chemotherapy. Give several cycles, shrink the tumors, and then go back for surgery later. That's called interval debulking. The chapter says this approach achieves similar survival outcomes to primary debulking, but often with fewer surgical complications, and it gets the patient started on chemo faster.
And how much does the amount of leftover disease impact survival?
Dramatically. The source gives median survival numbers over 60 months if there's no gross residual disease after surgery, but only 28-42 months if macroscopic tumor is left behind, or if interval debulking was done. It really highlights the importance of that initial surgery.
Okay, so surgery is crucial. Then what? Usually chemotherapy.
Yes, after surgery, primary chemotherapy is the next step for most women with epithelial ovarian cancer, especially if it wasn't stage I grade 1. The standard is typically a combination of paclitaxel and carboplatin.
How is that chemo given? Intravenously?
Usually intravenously, yes. The source mentions some older studies showed survival benefits with intraperitoneal, or IP, chemo delivering it directly into the abdomen. But it's technically difficult, has more side effects, and the chapter notes it's increasingly replaced by IV carboplatin and paclitaxel, which seem to offer similar results with less hassle. With optimal surgery in this standard platinum-based chemo regimen, the dose is given as carboplatin AUC 6.0 plus paclitaxel 175 mm DNR. The response is pretty good. About 70% of women with advanced disease see their tumors shrink, and 40–50% achieve a complete remission, meaning no detectable cancer.
That sounds promising. Are there newer treatments mentioned beyond standard chemo?
Yes, definitely. The chapter highlights PRP inhibitors drugs like niraparib or olaparib. These are often given as maintenance therapy after the initial chemotherapy finishes.
Maintenance therapy to prevent recurrence.
Exactly. And the data suggests they substantially delay recurrence and likely improve overall survival, especially for patients who have BRCA mutations or other defects in their tumor's DNA repair system, known as homologous recombination deficiency, or HRD. These drugs exploit that weakness.
So surgery, chemo, maybe PIRP inhibitors. Does this mean most women are cured?
Unfortunately, no. Despite these treatments, the chapter states that the majority of patients, even those who achieve remission, will eventually experience a recurrence, usually within 1 to 4 years after finishing primary therapy.
That's tough. How is recurrence usually found and managed?
Often, the CA-125 level starts to rise again first. Then a CT scan confirms the cancer is back. Recurrent disease can often be managed, sometimes for years, with further treatments, but is very rarely cured at that point. The source specifically says more surgery for recurrence hasn't shown a survival benefit in trials. Treatment for recurrence depends partly on how long it's been since the last platinum chemotherapy. If it's been a significant time, what's called platinum-sensitive relapse, they're often treated again with platinum combinations, carboplatin plus something like liposomal doxorubicin, gemcitabine, or a taxane.
What happens when the cancer just stops responding to these chemotherapies?
Eventually, all women who relapse develop chemotherapy-refractory disease. The source mentions common problems leading up to the end of life include refractory ascites that keeps coming back, poor bowel function or obstruction, or tumor growing into the bowel wall. At that stage, treatment becomes palliative, focused on quality of life and symptom control. This might involve limited surgery for bowel obstruction, localized radiation for pain, or palliative chemotherapy with agents that still have some chance of shrinking the tumor, even if briefly. The chapter lists gemcitabine, topotecan, liposomal doxorubicin, and bevacizumab as options with response rates over 15%.
We talked about survival by stage. The source also mentioned grade is important.
Yes, histologic grade, how abnormal the cells look, is a major prognostic factor, independent of stage. The 5-year survival numbers are striking. 88% for well-differentiated, grade 1, 58% for moderately differentiated, grade 2, and only 27% for poorly differentiated, grade 3. Interestingly, the specific type of epithelial cancer, like serous versus endometrioid, seems to matter less for outcome than stage and grade.
Okay, that covers the main epithelial type in detail. What about the less common ovarian tumors? Borderline tumors, for instance.
Right, borderline tumors. These are considered type 1 tumors, often found in younger women, maybe 30s to 50s. They have low malignant potential, meaning they rarely behave aggressively. Prognosis is excellent, nearly 98% 10-year survival.
Do they ever cause problems?
Recurrence can happen, but it's usually also indolent, slow-growing. Certain features like micropapillary patterns or microinvasion might signal slightly more aggressive potential. It's important to distinguish them from true, low-grade serous carcinomas. Treatment is surgery. Chemo and radiation don't seem to help much, according to the source.
What about stromal tumors? You mentioned earlier they can sometimes make hormones.
Exactly. They're uncommon, maybe 7% of ovarian neoplasms. They arise from the supportive mesenchymal cells. Most are slow-growing with limited tendency to spread. They often present just as a mass, maybe found incidentally or causing pain if they twist or rupture.
And the hormone production.
That's the notable feature, though rare. Some make estrogen, which can cause things like breast tenderness, early puberty in girls, menstrual issues, or postmenopausal bleeding. These women might even have other estrogen-linked cancers like endometrial or breast cancer at the same time. Others, like Sertoli-Leydig tumors, can make androgens, causing hair growth or virilization. Some are hormonally inert, like fibromas, which can sometimes be associated with ascites and pleural fluid Meigs syndrome. The source also links some stromal tumors to inherited syndromes, like Ayer's disease or Poitz-Jeghers. Treatment is almost always just surgical removal. Chemoradiation is reserved for very rare recurrent cases.
And the last group, germ cell tumors.
Yes, these are the ovarian counterparts to testicular germ cell cancers. They arise from the primordial germ cells, the ones that form eggs. Because these cells are tutipotent, they can turn into various tissues, leading to a range of tumors. Benign teratomas, also known as dermoid cysts, are common. Malignant types include dysgerminoma, immature teratomas, yolk sac tumors, and others.
Dermoid cysts are pretty common, right? Filled with hair and teeth sometimes.
That's them. They're the most common germ cell tumor, often found in young women, containing tissues from all 3 embryonic layers. Rarely, in older women, they can undergo malignant transformation, usually into squamous cell carcinoma.
When do the truly malignant germ cell tumors usually appear?
They peak in adolescence and young women. They often present as large, rapidly growing masses causing pain or a palpable lump. Some produce tumor markers like HCG, the pregnancy hormone, or AFP, alpha-fetoprotein, which can be measured in the blood.
Do they spread differently than epithelial ovarian cancer?
Yes, the source notes they have a higher tendency to spread to lymph nodes or through the bloodstream, hematogenous spread.
And treatment, is the outlook different?
Hugely different, and generally much better. Because they occur in young women and are often only on one side, except dysgerminoma sometimes, the standard surgery is usually just removing the affected ovary and tube, unilateral salpingo-oophorectomy, plus lymph node sampling. trying to preserve fertility.
What about chemo for advanced germ cell tumors?
For advanced malignant germ cell tumors, the chemotherapy regimen is BEP, bleomycin, etoposide, and cisplatin. This is the same highly effective chemo used for testicular cancer. And here's the key message from the source. Even with advanced stage disease, cure is expected in the majority of patients. Dysgerminoma, the ovarian equivalent of seminoma in testes, is especially curable. While it's sensitive to radiation, BEP chemo is preferred because it's just as effective, if not more so, and avoids causing infertility.
Okay, shifting gears slightly. The chapter mentions fallopian tube cancer. We talked about type 2 ovarian cancers potentially starting there. How does primary fallopian tube cancer fit in?
It fits perfectly with that new understanding. Since the evidence points to the fallopian tube epithelium as the origin for many high-grade serous ovarian cancers, it makes sense that cancers diagnosed as primary fallopian tube cancers are typically that same series of histology. The source is quite direct. These fallopian tube malignancies share the same biology and treatment recommendations as serous ovarian cancer.
So essentially, whether it's diagnosed as starting in the tube or the ovary, if it's that high-grade serous type, it's treated the same way.
Pretty much, yes. They often present as a mass near the tube, but spread early throughout the abdomen, behaving just like ovarian cancer. The source literally says their natural history and treatment are essentially identical and refers back to the same staging table, table 89-1. It really highlights how connected these structures are pathologically.
Let's move down the reproductive tract to cervical cancer. The source calls it a major global health issue.
Absolutely. Globally, it's cited as the second most common and the most lethal cancer in women. Huge burden, especially in lower resource countries. In the U.S., thankfully, incidence and mortality are much lower due to screening, but still significant, around 14,500 cases and 4,300 deaths estimated for 2021.
And the primary cause is very well established, isn't it?
Overwhelmingly, yes. Infection with high-risk strains of the human papillomavirus HPV is identified as the main initiating event in the vast majority of invasive cervical cancers.
How does HPV actually cause cancer? What's the mechanism?
So HPV is a DNA virus that infects the skin-like cells, the epithelium, particularly in the cervix's transformation zone, where cell types meet. There are many HPV types, but about 20 are considered high risk for cancer. HPV 16 and 18 are the most notorious, but others like 31, 33, 35 are also implicated.
Most people get exposed, right? But don't get cancer.
Exactly. Most sexually active adults encounter HPV, and most women's immune systems clear the infection. But in a minority, the infection persists. These high-risk HPZ types make proteins, specifically E6 and E7, which interfere with crucial cell cycle regulators, think P53 and ARB, the cell's natural brakes on uncontrolled growth. They essentially immortalize the cell.
But that's not cancer yet.
No, not full transformation. But in women with persistent infection, the HPV DNA often integrates into the host cell's genome. Over months to years, this, combined with other factors, can lead to worsening dysplasia precancerous changes. Getting from dysplasia to invasive cancer takes years and requires additional genetic mutations beyond just the HPV infection.
What did the genomic analysis, like the Cancer Genome Atlas, find specifically?
TCGA found HPV sequences in almost all the cancers they studied that were linked to HPV-18 and most linked to HPV-16. They also saw a specific mutation pattern called an ApoBec signature, suggesting host enzymes might be involved in driving mutations. Genes significantly mutated, likely pushing dysplasia towards carcinoma, included ERBB3, CASP8, and TGFRB2. Interestingly, for the small subset of HPV-negative cervical cancers, more common in older women, they found different mutations. KAS, ARID1A, PT, they were common. Suggests a different path to cancer.
Okay, since it's this long process from infection to dysplasia to cancer over years, this provides a window for prevention or early detection.
Absolutely. That long lead time is the entire basis for successful prevention strategies, particularly the Pap smear.
The Pap smear, how effective is that?
Hugely effective, especially where screening programs are well established. It detects those asymptomatic pre-invasive dysplastic changes during a routine pelvic exam. Finding and treating dysplasia, usually with simple surgical procedures, dramatically reduces the incidence of invasive cervical cancer.
What about adding HPV testing directly to the screening process?
HPV testing is more sensitive, it picks up more abnormalities, but as the chapter notes, it's less specific. It flags many transient infections that would clear on their own, potentially leading to more follow-up and anxiety than necessary. So there's a balance. The source also highlights the challenge in lower-income countries. Pap smears require infrastructure labs, trained pathologists, which isn't always available. That's why there's a big push for simpler point-of-care screening and treatment methods for those regions.
And beyond detecting early changes, can we prevent the initial infection?
Yes, with the HPV vaccine, that's primary prevention. Current vaccines protect against the highest risk types, like 16 and 18, plus others depending on the vaccine. Vaccinating girls, ideally before they become sexually active around age 11-13, drastically cuts infection rates and subsequent dysplasia.
What about vaccinating boys?
That's increasingly recommended too. It reduces transmission to partners and also protects boys from other HPV-related cancers, like throat cancers. The chapter does remind us that even vaccinated women should still get screened, as the vaccines don't cover absolutely all cancer-causing types.
Besides HPV itself, what are the clinical risk factors mentioned for actually developing cervical cancer?
They mostly relate back to HPV exposure patterns. Having many sexual partners, starting sexual activity at a young age, a history of other STIs. Smoking is also listed as a cofactor, making cancer more likely if you have HPV. And HIV infection, especially with a weakened immune system, low CD4 count, increases the risk and potentially shortens the time to invasive disease.
What kind of cancer is it usually, under the microscope? Histology?
Most are squamous cell carcinomas linked to HPV. Adenocarcinomas, arising from glandular cells, are also usually HPV-related. Both tend to start in that transition zone in the endocervical canal. The source mentions that lesions hidden deeper in the canal or glands can sometimes be missed by visual checks or pap tests. And it reminds us HPV causes other cancers too, vulvar, anal, pharyngeal.
How does it actually present when it becomes invasive cancer? What are the symptoms?
Again, early cancer is often asymptomatic, hence the need for screening. When it gets larger and invasive, symptoms appear. The classic one is postcoital spotting, bleeding after intercourse. Also, bleeding between periods or unusually heavy or prolonged periods. Sometimes a persistent foul-smelling yellowish discharge. Signs of more advanced spread include things like deep pelvic or back pain, suggesting the tumor is pressing on nerves. Leg swelling or flank pain could mean ureters are blocked, causing kidney swelling, hydronephrosis, or that pelvic blood vessels are compressed, possibly causing a DVT. These point to spread to the pelvic sidewall or extensive lymph node involvement.
How is cervical cancer staged? Is it based on surgery, like ovarian?
No, this is a key difference highlighted in the source. Cervical cancer staging is done by clinical exam, what the doctor finds on pelvic exam, plus maybe some basic imaging or procedures like cystoscopy or proctoscopy if symptoms suggest bladder or rectum involvement. Figure 89-2 in the source lays out the stages. Stage 0 is carcinoma in situ, precancer 100% survival. Stage 1 is confined to the cervix, 85% 5-year survival. Stage 2 extends beyond the cervix but not to the pelvic wall or lower third of the vagina, 65% survival. Stage 3 reaches the pelvic wall or lower vagina, 35% survival. And Stage 4 invades nearby organs like bladder rectum or has distant metastases, only 17% survival. Although staging is clinical, the source clarifies that modern imaging like CT and MRI is crucial for treatment planning. MRI is particularly good for seeing exactly how far the tumor extends locally.
Okay, treatment depends on that clinical stage. How is it treated?
For very small, early-stage eye tumors, surgery can be curative. Options include hysterectomy. However, the chapter makes an important point based on recent trials. Minimally invasive surgery, laparoscopic or robotic, for these early cancers seems to have worse outcomes compared to traditional open hysterectomy.
That's surprising. What if a young woman wants to preserve fertility?
For selected young women with early-stage disease, a procedure called trachelectomy might be possible. That removes the cervix and vagina, but leaves the uterus intact, allowing for future pregnancy, although those pregnancies carry higher risks. But for larger stage eye tumors, say over 4 centimeters, and for all stage 2, 3, and 40 patients, the standard treatment is not surgery. It's combined chemoradiation radiation therapy given concurrently with cisplatin-based chemotherapy.
How effective is chemoradiation for those more advanced stages?
It offers a real chance of cure, even for locally advanced disease. The source quotes cure rates ranging from 40% to 80% depending on the exact stage and other factors.
What about when cervical cancer has already metastasized to distant sites?
For metastatic disease, the goal shifts to palliation controlling the cancer, managing symptoms. The standard first-line palliative chemotherapy is usually a platinum agent, cisplatin or carboplatin, combined with paclitaxel, often with the addition of bevacizumab, a drug that targets blood vessel growth. The chapter notes that once that first-line chemo stops working, further lines of chemo offer minimal benefit for most patients. However, it does mention promising results emerging for immunotherapy, immune checkpoint inhibitors, or adoptive T-cell therapies, particularly for recurrent or unresectable cases.
All right, let's move up into the uterus itself. Uterine cancer. What are the main types found there?
So the uterus has different parts. Most cancers arise from the lining, the endometrium. These are endometrial adenocarcinomas. But you can also get tumors from the muscle wall, the myometrium. Benign ones are varicose leiomyos or fibroids. Malignant muscle tumors are leiomyosarcomas. These are treated very differently from endometrial cancers.
Which uterine cancer is the most common GYN malignancy in the U.S.?
That would be the endometrioid subtype of endometrial adenocarcinoma. The source states it's the most common gynecologic cancer in the U.S. Over 66,000 cases expected in 2021, nearly 13,000 deaths.
What's the main driver for that common endometrioid type?
Estrogen. The chapter really emphasizes the role of estrogen in driving the growth of the endometrial glands. The key risk factor is prolonged or excessive exposure to estrogen, especially if it's not balanced or opposed by progesterone. Progesterone makes the glands mature, which is protective.
So situations leading to unopposed estrogen increase risk?
Exactly. The source lists things like obesity, fat cells make estrogen, women taking estrogen replacement therapy after menopause without adding progesterone, and women with rare estrogen-producing ovarian tumors. Also, long-term use of tamoxifen.
Tamoxifen, the breast cancer drug.
Yes. While it blocks estrogen in the breast, it can act like a weak estrogen in the uterus, increasing the risk of endometrial cancer over time.
Are there inherited risks for uterine cancer too, like Lynch syndrome?
Yes, definitely. Lynch syndrome, HNPCC, caused by inherited mutations in DNA mismatch repair genes, MSH2, MLH1, etc., significantly increases the risk for endometrial cancer. It's the most common cancer associated with Lynch syndrome after colorectal cancer. The chapter quantifies it. Middle-aged women with Lynch have about a 4% risk per year and roughly a 200-fold increased lifetime risk compared to the general population. Huge increase.
What about genetic changes in non-inherited sporadic uterine cancers?
In those cases, often related to estrogen excess, the source suggests secondary genetic events act as additional hits. Common ones include mutations in the PI3K pathway genes or loss of the PTN tumor suppressor gene. The genetics of the less common, often more aggressive types, like clear cell and papillary serous uterine cancer, are less well understood but seem different.
The chapter mentions different histological types besides endometrioid. How important are they?
They are important because they behave differently. About 75–80% are adenocarcinomas, broadly split into type 1, estrogen-driven, usually endometrioid, lower grade, and type 2, less estrogen link, include clear cell, serous, mucinous types, often higher grade.
And type 2 is generally more aggressive.
Yes, particularly the endometrial serous cancers. The chapter notes they often have TP53 mutations similar to high-grade ovarian cancer, and they have a higher risk of spreading systemically, even when seemingly confined to the uterus. Prognosis overall depends on stage, grade, and how deeply the tumor has invaded the uterine muscle wall.
How does uterine cancer typically show up? What are the symptoms?
This is a key feature and often a saving grace. The vast majority, around 90%, present with postmenopausal vaginal bleeding.
Bleeding after menopause.
Exactly. That's usually caused by the malignant lining shedding. In premenopausal women, it might be abnormal bleeding between periods. Because bleeding is such an obvious sign, it usually prompts women to seek medical attention relatively early.
So most are caught early.
Yes. Consequently, most women present with early-stage disease still confined to the uterus. This leads to a generally high cure rate compared to, say, ovarian cancer. Uterine sarcomas, the muscle tumors, often present differently, maybe as large pelvic masses causing pain or pressure, sometimes with bleeding too.
How is the diagnosis confirmed?
Usually with an endometrial biopsy. A small sample of the uterine lining is taken, often in the office, and examined under a microscope.
Since most are caught early, stage I, what's the standard treatment?
For localized disease, which is the case for about 75% of women, definitive treatment is typically surgery. A total hysterectomy, removing the uterus and cervix, along with bilateral salpingo-oophorectomy, removing both tubes and ovaries.
What about lymph nodes? Are they removed like in ovarian cancer staging?
This is different. The source states that routine removal of pelvic and periaortic lymph nodes does not improve survival outcomes in endometrial cancer. However, checking the sentinel nodes, the first nodes draining the uterus, is important for staging and prognosis. Fighting cancer with the nodes makes it stage IC.
After surgery for early stage cancer, what determines if more treatment is needed? Adjuvant therapy.
The two main factors driving that decision are the tumor grade and the depth of invasion into the uterine muscle, myometrium. Women with low-grade tumors that have invaded less than halfway through the muscle wall usually need no further treatment after surgery, just observation.
And if it's higher grade or deeper invasion?
Patients with high-grade tumors or deep invasion, stage LB invading 50% of the myometrium, have a higher risk of the cancer coming back in the pelvis, particularly at the top of the vagina, the vaginal cuff. This risk is typically reduced by giving adjuvant intravaginal brachytherapy, a form of internal radiation focused just on that area.
The source mentioned MSI testing being important.
Yes, microsatellite instability testing. This looks for defects in those mismatch repair genes, often linked to Lynch syndrome, but also occurring sporadically. MSI-high tumors have lots of mutations. The chapter recommends routine MSI testing on endometrial cancers.
Why is MSI status important?
Because MSI-high cancers, if they recur or are advanced, are much more likely to respond to immunotherapy, specifically immune checkpoint inhibitors. So it guides treatment choices.
Okay, what about treatment for advanced or recurrent uterine cancer, when it's spread beyond the uterus?
For women with regional or distant metastases, stage 3 or 4, about 3% at diagnosis or later recurrence, treatment depends on the tumor type and grade. Low-grade estrogen receptor-positive tumors might respond to hormonal therapies like progestins or tamoxifen. Poorly differentiated tumors usually lack hormone receptors and don't respond well to hormones. For early-stage disease, adjuvant chemotherapy after surgery is generally only considered for the high-risk serous type. For more advanced stages, chemotherapy and/or immunotherapy are used because the risk of systemic recurrence is much higher.
What's the standard chemotherapy regimen?
Similar to ovarian cancer, carboplatin and paclitaxel combinations are the current standard. For metastatic disease, chemo is usually given with palliative intent to control the disease, not necessarily cure it. As we mentioned, patients with advanced MSI-high cancers may respond very well to immunotherapy targeting the PD-1/PD-L1 axis. The chapter also notes a combination of lenvatinib, a targeted drug, and pembrolizumab, an immunotherapy drug, shows promise even in MSI-stable tumors, though long-term survival data was pending. Other options mentioned include bevacizumab, MTOR inhibitors, and anthracyclines. For uterine sarcomas, it's different again. Carcinosarcomas, mixed tumors, might respond to paclitaxel platinum. Leiomyosarcomas, the most common muscle type, are often treated with docetaxel at recurrence. Adjuvant chemo after surgery doesn't seem helpful. Other drugs like ifosfamide or trabectedin might be used later.
And survival by stage for uterine cancer overall, using table 89:1 again.
Pretty good for early stages. Stage 1 is over 90% 5-year survival, stage 2 around 75%, stage 3 drops to 45-60%, and stage 4 is about 20%. Early detection really pays off here.
Okay, one last category to cover. Gestational trophoblastic tumors. These sound completely different.
They are very different. They don't arise from the woman's own reproductive tissues, but from the trophoblasts, the cells that form the placenta during pregnancy. It's a spectrum, from benign conditions like hydatidiform moles, molar pregnancies, to malignant cancers like choriocarcinoma. They usually arise after a molar pregnancy, but sometimes can occur after a normal pregnancy, miscarriage, or even ectopic pregnancy. The common forms are partial and complete molar pregnancies. Incidence varies. It's higher in Southeast Asia, maybe linked to diet, low carrot and animal fat mentioned. In Western countries, it's rarer, maybe 1 in 1,500 pregnancies.
What actually causes a molar pregnancy?
It's an abnormal fertilization event. Complete moles are diploid, normal chromosome number. But weirdly, all the genetic material comes from the father. It's thought one sperm fertilizes an empty egg and then duplicates its DNA. Yet lots of placental tissue growth, often with cystic swelling, hydropic changes, but no fetal development.
And partial moles.
Partial moles happen when 2 sperm fertilize 1 normal egg, resulting in a triploid conceptus, 3 sets of chromosomes, 2 paternal. You get some placental changes, less dramatic than a complete mole, and some fetal development can occur. But it's abnormal and usually ends in spontaneous abortion. Lab findings often show extremely high levels of the pregnancy hormone, HCG, and sometimes high AFP.
What's the risk that the disease persists after the mole itself is removed, like by D&C?
After a partial mole, the risk of needing further treatment for persistent gestational trophoblastic disease, GTD, is quite low, around 5%. After a complete mole, the risk is significantly higher, maybe 15% to 25%.
How does that persistent or invasive disease show up?
In places with good access to care, early pregnancy detection and ultrasound usually find molar pregnancies early. The woman has typical early pregnancy symptoms. After the uterus is evacuated, most cases resolve on their own, which is monitored by tracking serum HCG levels back down to 0. But if the HCG levels plateau or start rising again, or if imaging shows persistent tumor or metastases, that indicates persistent GTD requiring therapy.
What if there isn't early prenatal care?
Then the presentation can be much more dramatic and dangerous. Very high HCG levels can cause severe complications, mimicking preeclampsia or eclampsia, or even hyperthyroidism. Evacuating a very large mole can also be risky, with potential for uterine perforation, hemorrhage, heart failure, or lung problems, ARDS.
How is the risk level assessed to decide on treatment for persistent GTD?
There are scoring systems based on factors like HCG level, time since pregnancy, sites of metastases, etc. These systems categorize patients into low, intermediate, or high risk. This helps determine who needs single-agent versus multi-agent chemotherapy. High-risk features generally include widespread non-lung metastases, very high HCG, or disease occurring after a normal-term pregnancy. These cases need expert management.
What's the overall outlook for invasive GTD? Can it be cured?
Yes, this is one of the real success stories in oncology. The source states the management goal is essentially 100% cure. Even complex, high-risk cases should be managed by experts with the expectation of cure. For persistent disease after a mole, chemotherapy is the standard treatment. Surgery might play a role occasionally, like removing resistant disease isolated in the uterus if fertility isn't desired, or controlling bleeding.
So chemo is the mainstay.
Yes, especially for women wanting to preserve fertility or those with metastatic disease. The chapter describes trophoblastic disease as exquisitely sensitive to chemotherapy. Successful curative treatment is considered the rule, with treatment guided by following those serum HCG levels down.
What chemo drugs are used?
For low-risk disease, single-agent chemo with either dactinomycin or methotrexate cures about 90% of patients. High-risk patients, those with the high-risk features we mentioned, or who fail single-agent therapy, get multi-agent chemotherapy. The standard is often EMA-CO, etoposide, methotrexate, dactinomycin, alternating weekly with cyclophosphamide and vincristine.
And that works even for widespread disease.
Yes, EMA-Q is typically curative even with extensive metastases, like lung mets. For the very highest risk patients, for example with brain or liver mets, an even more intensive regimen involving cisplatin and etoposide alternating with EMA-Q might be used. A key risk mentioned, especially when starting chemo in high-risk patients with lots of tumor burden in lungs, liver, or brain, is hemorrhage for the tumors themselves because they have such a rich blood supply.
Can women who are cured of GTD have healthy pregnancies later?
Yes, absolutely. The source notes that cured women can go on to have subsequent pregnancies without any evidence of increased risk of complications for either the mother or the baby. A truly remarkable outcome.
Wow. Okay, that really was a deep dive into Chapter 89. We've gone through ovarian, fallopian tube, cervical, uterine cancers, and gestational trophoblastic tumors, covering their origins, how they behave, detection, treatment, all based on the details in this specific chapter.
We really have. We've seen the huge impact of things like genetics BRCA, Lynch syndrome, and infectious agents like HPV and hormonal factors. We've contrasted the real challenges in screening for some, like ovarian cancer, with the incredible success stories in prevention and screening for others, like cervical cancer with pap smears and HPV vaccines.
And the outcomes vary so much, don't they, depending on the cancer type, the stage at diagnosis.
Dramatically. From the often difficult prognosis of advanced epithelial ovarian cancer to the generally expected cure for malignant germ cell tumors and gestational trophoblastic disease, even when advanced. It's a wide spectrum.
It's clear these are complex diseases, definitely, but it's also clear that progress is being made, understanding the genetics, refining surgery, developing chemotherapy, targeted therapies, immunotherapy. It's making a tangible difference.
Indeed. And mastering these details, understanding these nuances from the source material, is really vital for appreciating the whole landscape of gynecologic oncology.
So what's the final takeaway here? As you, our listener, reflect on all this detail, maybe consider that stark contrast. The difference in outcomes between catching these cancers early versus late, and the ongoing challenge, the frustration of not having effective screening for some of the most lethal types like ovarian. It really poses a question, doesn't it? How can we best apply the knowledge we do have about risk factors, about symptoms, about the successes in cervical cancer prevention to try and improve early detection and outcomes across the board? Something to think about. We hope this very deep dive into Chapter 89 has given you that expert-level understanding you were aiming for.
It was fascinating to go through the chapter in this much detail. Thanks for guiding us through it.
Thank you. We'll be back soon with another deep dive.